Good afternoon, everybody. My name is Jason Belden. I'm the Director of Emergency Preparedness for the California Association of Health Facilities. And today is our COVID Weekly Roundup. It's March 15th, 2020. It's 1 p.m. Pacific time. We're going to cover briefly some of the AFLs that came out this week, and then we're going to dive into the mitigation plan requirements and the CAF template that we've produced. And I'll talk about each one of those things in depth as we go. And just as a reminder, if you have questions, you can enter them into the question box and we'll get to those at the end of the program. Boy, has it been a busy week, guys. You know, I keep waiting for a week to go by where I'm not listing out multiple AFLs that have been either updated or issued for a week, but just this week, these are the AFLs that were either updated or sent out. And this may actually not be all of them, because I think there was a daily reporting one that's came out yesterday too. But anyways, we'll talk about those. So the very first one is an updated list of the symptoms that we should be screening for at the door when we do our symptom screening. The second AFL that came out was in regards to the Battelle system, which is a decontamination system for the N95 masks. There's a process for you guys to, free of charge, have your N95 masks decontaminated. If you click on the link, or if you just go to the AFL section of the CDPH website where they're all listed, look for AFL 2036 and it'll describe the process for that. I'm not going to dive into the daily reporting. As you guys know, it's ripe with inconsistencies and errors. As long as we are inputting our daily stuff and we're keeping proof that we're inputting it, I think we can figure out the technical difficulties about making sure that it displays that you're correctly reporting and things like that. And then lastly was the mitigation plan requirements that came out on Monday. And those are the ones we're really going to dive into now, because this is going to be required, and the requirements are pretty lengthy if you look at the checklist that they provided. So we're going to go over that in a second. But I think I put a slide in here in regards to the CDPH daily reporting. We know there are errors, guys. We're addressing it multiple times a day with the department. I'm not going to get into this, but just know that Patty Owens, CAF's regulatory director, is working with CDPH to finalize those issues. On Wednesday, we thought it was, when I put this together, this PowerPoint, actually, I think I finished it yesterday, and about this time yesterday. And after that, CDPH has said they're going to start moving to one report. They're going to try to build in that information for the NHSN reporting into one full report. I'm not convinced that that we've tackled the technical issues of why things are not being reported after you guys have done it, but trust that, just be patient. We're going to get this worked out, and we'll advocate on your behalf to let them know that you're inputting the information correctly and that the issues are with the system and not with the reporting. So, and then our job is just to make sure that we do a good job of reporting every day at 7 days a week as the requirement. All right. So many of you have seen this mitigation plan, and it listed 6 separate components as a requirement of the mitigation plan. Testing and cohorting, so they can kind of combine really 2 things into one there, but testing and cohorting. And the thought is the testing will lead to the cohorting, and we'll dive into that in depth. Infection prevention and control, PPE, emergency staffing. Sadly, we're defined, all of us are defined by the limitations of the few. And so the department, when they came up with these kind of requirements that they think a mitigation plan should have, it's based on what they've seen happen in other facilities. What are the things that could help them prevent having these massive staff problems where the staff either turns positive and doesn't show up or refuses to come in or whatever the case is. Their concern is that folks don't have a good idea of how they're going to staff the building if something like that happens. So they want to see something spelled out in writing as to how you're going to accomplish that. The good part is the emergency staffing piece. A lot of us are real familiar with that. Now, we've not had to deal with it where 30 or 40 or 50 of our staff are quarantined, but we do have a process for dealing with emergency staffing that we've done through disasters, for the last 10 years. So you guys have an emergency staffing piece already, and it's kind of tying in that emergency staffing piece to what you're currently doing. And then designated space. This is an all new thing. This is not something we've really thought of before. We've talked about it. We've talked about having a plan to, contain folks, isolate them, what that looks like, what are procedures we can do to minimize cross-contamination, things like that. Those will need to be spelled out in your mitigation plan. And we'll borrow real heavily from lessons learned and the guidance given to us from CDC when we develop our internal plan for that. And then the communications piece. So last part, this is really what they ask for in the AFL is not, it's not a tremendous amount, and it might actually align with what you're already doing now. And we'll talk about what those expectations are. Then, and we can see if you guys are actually already doing that. And many of the components you're already doing. I'll just say that a lot of the things in here you're doing by another name, and we'll try to help you pull those documents in and create it into one thing. I just want to make this clear. Many of you already have a mitigation plan. Now, it may not contain all of the 6 elements that CDPH highlighted, but my suggestion is don't get rid of your plan. If your plan is based on procedures that are working for you, just supplement that mitigation plan to make sure it covers the 6 components that CDPH has identified. So I said that twice. You may use your own plan, you may use your own plan, you may use your own plan. This plan that we've created as a template is going to require you to customize it. So it's going to be your plan anyways. CDPH has asked us to have you include the checklist with your plan that you submit. And it's important to choose procedures you can accomplish. As you read through our mitigation plan template, it's just going up on the website now. So I know you guys don't have a lot to refer to. I'm going to go over the highlights, but I think as we go through this, because of the complexity involved in some of the procedures that we've seen other providers use, may not work for your building. There are going to be things with our physical space that are going to be virtually impossible to accomplish. So I want you to look at each one of these procedures. I know it's a lot of work, and it's going to take a lot of your team to review this stuff, but you'll have to review this. If you're going to use our template, make sure that you can meet these suggested procedures. And where you can't, we're going to have you remove those and either add in stuff that you think you can accomplish or remove them altogether. And the expectations from CDPH is really that your plan align with that checklist. I will say that there are things in that checklist that I don't think are achievable. And in cases where what they're asking you to do is not realistically achievable, don't put that into your plan, because if you put it into your plan, you're going to be responsible for making sure that you meet what's in the plan. So make sure it's what you can achieve, make sure it's what you can do. I realize CDPH has that checklist, but if you're going to be automatically non-compliant the minute you submit your plan, then it doesn't work. So we want to make sure that the plan is achievable, and we'll let CDPH tell us what the best recommendation to accomplish those goals are if our plan does not work. All right. So let's talk about how we've set up our mitigation plan template. Within we always think a plan should be based on objectives that you have set out to achieve with the policies and procedures contained within the plan. And so the kind of the objectives that we want to meet, obviously we want to have an overarching goal of protecting life safety in the building. If we have a fire or a flood or other things, those immediate needs need to override our mitigation plan template. So I want you to think about a mitigation plan template, or this template. It's in conjunction with your emergency operations plan. We'll ask you to pull in documentation from other parts of your emergency operations plan, other things like that to supplement the mitigation plan. We set it out with the following kind of objectives. We've got the standard objectives about maintaining a safe environment and sustaining our organizational functional integrity. But we want to respect the rights of the staff and residents and staff to choose to be tested. I know that has been many conversations with us have been about staff not wanting to get tested. We'll get to that in a second, but that is one of our objectives, is to get testing for residents and staff within a clinically valuable time frame in a way that respects their right to choose. One of our goals is going to be the consistent procurement of PPE and sufficient supply to meet daily need, with a goal of maintaining an ongoing 14-day supply. If you looked at the checklist provided by CDPH, it doesn't say a goal. It says you have to have 14 days. And we've consistently told CDPH that 14 days of our normal supply is vastly different than 14 days of supply during an outbreak. So what 14-day supply are we looking at? Are we looking at what we normally have? Because that's probably achievable. If we're looking at 14-day supply during a pandemic, that's probably not achievable unless we get some support from other agencies or entities like the MOOC or something like that, or FEMA or other distribution of supplies. The next objective would be to design or designation of space that can be safely used to isolate COVID positive patients. And then we'll define and describe a process for the acquisition of emergency staffing, because that has to be in there, guys. So those are kind of our overarching objectives of what goes into building this plan. We put a resident profile document section in there because we think it may be helpful in identifying acuity problems that may exacerbate your ability to cohort people. So we want you to, in our document, it's as simple as attaching Form 802 and then referring to your facility assessment for additional resident needs and conditions. But you can attach that document to the mitigation plan, and that will talk to the type of residents that you have in the facility. I mentioned the companion documents. As you go through our template, you're going to see tons of stuff that's highlighted. Obviously, if you leave that highlighted stuff in there, it's going to draw a red flag from CDPH that you did not customize it. So you're going to have to remove all the highlighted sections, and they're highlighted because you'll need to either add stuff in there or you'll have to remove that language. So, and we'll refer to the companion documents because there's going to be a bunch that are going to have to go with this. Testing residents and different strategies. So we know that the goal is to, at least the goal from CDPH, is to test every staff member and every resident in a skilled nursing facility. Even skilled nursing facilities not currently having an outbreak or without any symptomatic people. Now, we've convinced them to do that in concert with your local health departments. And so the process for that is going to be vastly different across county lines. Some local health departments will, I'll give you an example. Sacramento has a strategy to test every single facility with their public health lab, and they're going one by one. And In counties where the spread isn't as aggressive, maybe that kind of methodical approach going from one facility to another will work. And that's going to work for their local health department until they tell us different. In Los Angeles, they've told us we're only going to go out and test facilities that have one or more person in that has tested positive. So they consider an outbreak one or more staff or one or more residents. So they'll go out and test the entire facility and the staff if that's the case. If that's not the case, the local health department in Los Angeles wants you to develop a program to do surveillance testing on 20% of your staff or of your residents on an ongoing basis. They have not said anything about testing staff, and there's still some question as to how we can do that, where this can be accomplished. It's highly different in different communities. It makes it very hard to do. And that's why it's important for us to know, to demonstrate to CDPH that we're doing it in conjunction with our local health department, who CDPH has said has primary authority over the testing in our county. So we'll follow the local health department, and we want to put that into our procedure. So our very first procedure is going to be talking about that. So even if you're doing your own, that has to be in there. That coordination piece with your local health department to determine the process and when you're going to test and who's going to do the testing, all that has to be developed in conjunction with your local health department. Now, does that mean you have to use the local public health department lab to do your testing? No, it doesn't. But what you should do is, if you're going to use a vendor, or if you're in a managed care county and the managed care plans are going to come in and pay for to do the testing, if you have vendor agreements with labs that have the throughput to be able to do testing in a clinically valuable time, and I'll say less than 72 hours. If we test our building and we get the results 10 days later, we will have missed a big window of opportunity. Now, if we're masking and we're really diligent with our infection prevention and infection control, we should have very minimal risk of expanding that time, but I still think it's important to get those results back as quickly as possible. So that's kind of a highlights of the testing of residents. As we talk about testing of staff, we don't really have an idea of how this is going to work in each community. In some communities, they have Optum testing sites where all healthcare workers can go get tested free of charge. I don't know what the turnaround time is for those results and things like that. But whatever it is, the same kind of procedures would need to apply. I think the facility is going to need to coordinate with your local health department to, obviously, we're going to test any symptomatic staff through whatever means necessary, because we're going to assume if they're symptomatic, they're going to be positive. We're not going to have them in the building. We'll catch them at the door, hopefully, right? We're going to catch them at the door with their febrile symptoms or their slight temperature, things like that. We're going to catch them at the door. We're going to send them home. We're going to call the local health department. We're going to ask them to get our staff tested. But what do we do when we don't have outbreaks? And then luckily for us, that's still the vast majority of the buildings in the state. So if you don't have an outbreak, what is the procedure for testing staff? And I'll say that if you're doing a really good job with your infection and prevention and control, you're continuing to restrict movement within the building, you're practicing, those same social isolation things, you're minimizing risk or exposure risk inside the building and doing the symptoms checks, I think that strategy, universal source control, is going to help us really, really reduce not only outbreaks, but the severity of the outbreaks. We've talked to doctors in the public health docs in Los Angeles, which is a great way for us to learn because they've had so many facilities. Well over half of the buildings in Los Angeles have at least one case. So they have a good idea of what it looks like and things like that. And their suggestion on staffing is to do it in a surveillance fashion. Now, not every county is going to say that same thing, but if we do it and the reason being doing surveillance testing for staff is it's virtually impossible for us to have enough tests within a timely enough period to be able to test staff on a regular basis. And if the staff are exposed every single day when they go back out into the community, how effective is the testing unless we're doing it every day at the door and we're getting instant results? It makes one wonder whether we could even get to the point with the current testing modality that it would be effective, 100% effective. It definitely will help, but it won't be 100% effective. So then we look at, well, what do we do with staff that do test positive? There is an allowance. Most local health departments will allow those folks to work in COVID positive units. So, how they come into the building, the PPE they wear is all the same. So could we, is it necessary to test everybody? I don't know. The local health departments will have that kind of guidance. And if they're not, our suggestion in the template is to take a 10% random sampling of staff in the building on a monthly basis. But like I said, this is something that you guys have to live with. If you want to do 20% or whatever your choice is, or if you're just going to follow the local health department to do whatever they want to do, and if they don't do any, that's up to the local health department. But I'll say CDPH's expectation is that we at least get everybody tested once, and then have a procedure for ongoing testing, and then that'll be highly influenced by what the local health department does. All right. And then I mentioned that striking out on your own with the local health department. You're going to have to, local health departments have some capacity to test, and testing of staff and residents of skilled nursing facilities is a priority. It's listed on the tier 1 as a priority for the public health departments. There are also a number of other things that are requested of the public health departments, including testing all discharges from hospitals to SNFs. We know that's not happening with regularity, and we're working to get folks to do that. So in cases where the local health department is not aligned with what the state wants you to do, you certainly can strike out on your own and find testing labs. We've spoken to a couple of lab providers. One represents Osang Healthcare, which is a South Korean company that just came into the market and received, they're not the actual company in the United States, but it's their test kit that the company is using. Once we have information on viable solutions for you guys to send your testing to, we'll submit that and put it up on the website. The vast majority of labs or facilities use Trident as their lab partner, and they've been a partner of CAF for a long time. But if 800 or 900 facilities all of a sudden say, listen, I need to test everybody, I don't know if they have the throughput to deal with that. So we'll work to try to identify as many people as we can. And one of our communications with the Department of Public Health was to tell them, that's great. If these testing resources exist in supply, then please list them out for us where they exist, what payer sources they'll accept, and things of that nature. And I think they have an idea of some labs that we can use. Maybe they're labs that we don't have any relationship with. But as we get that information, we'll pass it out. I do know that some of the local health departments also have lists of labs that can do testing as well, Los Angeles specifically. All right, so that's the testing portion of the testing and cohorting. The cohorting thing is a part of your plan that will only be used if really you have an outbreak. So this portion of the plan wouldn't necessarily be activated unless you're having to divide people up based on their COVID status. Well, let's knock on wood and let's say you do mass testing and nobody comes back positive. Well, then we want to have a plan of what it looks like to, to cohort people if we do get an outbreak, but we don't have to activate this until we actually have the outbreak. The way we divided up our cohorting guide was a color-coded guide based on information that we've seen from other states doing this, and also from the CDC. So I'll say I stole this in theory from other states, but the reason why I think the reason why they did it in the color-coded fashion they did, it's like a stoplight. Green means go, yellow means caution, red means stop, right? So in our cohorting guide, as you look through it, we have divided it up into 3 sections. A section for positive COVID people and suspected symptomatic COVID residents. Obviously, that's full PPE. Unknown or untested without symptoms, those are going to be our yellow folks. And so that would be somebody, let's say you're in a county, I don't want to call counties out, I hate to do that, but I know counties are not testing discharges to SNFs, and if they're not symptomatic. And so those are the folks that we're going to look at as being put into a yellow space, because we have no confirmation that they are negative. We're going to assume that it's likely that they are positive, and we're going to treat them with full PPE until they've reached the end of the time-based requirement for the removal of transmission-based precautions. Now, these are all guides as best practices, guys. If the layout of your building does not give you the ability to divide it up into 3 sections, or maybe you don't have any yellows. I think ideally we're going to get to the spot where we have reds and greens, and we'll know, the yellow folks, because the hospitals will be testing every admission or every discharge to a skilled nursing facility. And then the last part is the green, and that's the easy part, because that looks a lot like the care we normally provide, except we're going to continue source control. We're still going to ask the residents if they can tolerate it and they're out of their room to please wear a face mask, things like that. Those are all going to stay static. These are very specific guidance procedures that we put into the template. So I'm telling you, go through it line by line by line and make sure you can do it, because the best practice for setting up a cohorted section to deal with COVID requires full staff, full supplies. Imagine if you were to divide your building up and that building was going to operate on its own, and to the extent you possibly can. Obviously, you're going to share a DON, and you're going to share an administrator. You're going to share some staff. But the idea is we're going to limit that, and those staff that oversee the entire thing are not going to be going in and out of those red spaces. So when I say look at the fine print, because these are just suggested procedures based on what we've seen other folks do in other states that have been more impacted than us. So I want you to pay attention to those greatly. If you've developed your own plan, look at these and go, gosh, either yes, I'm doing this and I'm calling it something different, I'm meeting the intent, or I'm not doing this and maybe this is a good idea for me to do. So I want you to highly review those things. A lot of what is in red and yellow look very similar, but we're not going to have people from red working in yellow. That's not what the red is. We want those folks to stay there because we know that's where the virus is. The yellows are the hardest to determine because we don't know. So we treat those folks with caution until we do know. And obviously the green folks are what we do every day. So infection prevention and control, I got to claim some level of ignorance as to what you guys currently do for infection prevention in terms of how you divide up those hours and who is doing that. This new requirement seems very aligned with what's currently in the ROPs, but it goes a bit further. So it calls for a full-time infection and preventionist, and I'm using air quotes around that because it does allow those duties to be shared with other staff members. So as long as it results in a full-time position, I think it meets the intent of the rule. That person is going to be your chief information officer, for lack of a better term, because they're going to collate all those separate guidance documents from CDPH, from CDC, from CMS, from local public health. All of that stuff is going to be used to give you specific procedures on the implementation of infection prevention and infection control. That person's also going to have their head on a swivel. As you guys know, I think we're at AFL 52 since the beginning of the year, and many of them have complex information that's changed multiple times. So that person has to have their head on a swivel. They have to adjust to the changing guidance, and they have to train the staff on the changing guidance. And we've seen it change all over the board. Although I think we've kind of got our head around most of this stuff, and just some of the counties are debating return to work, criteria, like how long does somebody stay out if they've not had symptoms versus if they have had symptoms. That is slightly different in some counties, but for the most part, we're starting to get some consistency with the infection prevention and infection control guidance and what each one of these regulatory bodies wants us to do just in those narrow scopes. But I'll say that we're all learning as we go with this, and so the lead that you have identified is going to be responsible for collating and influencing procedures after that. They're also going to be responsible for staff training of those infection prevention procedures and infection control procedures. Now, some of these things, the last two are recommendations. It doesn't call for that in the guidance documents, but it seems like it would tie into what they're already doing, and that would be overseeing and documenting the screening activities, or overseeing and documenting the screening and overseeing and documenting activities as it relates to infection prevention and control in your building. I didn't mention the training. So one of the things is they require the infection preventionists to be trained. It's a very nebulous term. I'm not sure that they have further defined what that training is required to be, but I do know that the Hospital Associated Infection Branch has said they have some online training. Now, normally it's an in-person training, but the PowerPoints and the training materials are on their website. You know what? Email us and I'll see if we can get a link to that, because I'm not sure they provided us that data, and I'd like to at least put it on the forum. But if somebody knows where that information is located, that'd be great. You can post it to the forum as well. All right, and we'll move on to emergency staffing. Gosh, emergency staffing in a pandemic looks a whole lot different than it does, in a flood or an earthquake or a fire. But generally, what CDPH's recommendation or requirements is to determine a minimum number of staff that you need for patient care. Break it out by shift, and really put some thought into 2 people go out. What do I do? Do I do staff call in? What are the things? Can I bring in other folks from other parts of the building to serve those needs? Things like that. All that needs to be fleshed out into this plan. And if you have a staff plan that you want to attach, you can attach it directly to this a staff recall plan, you're going to attach directly to this template. Factor in all the new requirements. So we're going to talk about PPE coaches, this new infection prevention thing, a dedicated person for doing communications. All of those are new and not a part of your normal day-to-day scope. And you're going to have to, take people from your existing staff to meet that extra scope of responsibilities. So factor that in when you're looking at your staffing model. CDPH has said over and over and over again that their goal or their expectation is that the facilities be self-sufficient to the extent possible. There are a lot of things that we cannot do that that are going to be outside of our control if we have a large outbreak in the facility. And I think they come around to understanding that. But things we have to understand is we have to understand our own staff recall process. Within this mitigation template, we have suggestions based on what we have used in other disasters before, for a look of kind of a decision-making process of how you get to the point where you ask for help. So that starts with, staff recall, making sure our staff are prepared and they understand the expectations, that we may ask them to come in for longer than, possible. We may ask them to work overtime. We may ask them to work in COVID positive, spaces. All of those things, we should have those conversations with folks beforehand. Normally, in an emergency, you would cancel, like employees scheduled, approved time off requests. We would normally cancel those. And that may be a procedure that you guys want to do. It's up to you, but that's in the emergency staffing strategies. It's not required for you to do that. That's just a helpful thought of what has worked before for folks trying to manage these events. The reason why I say this is different is because we don't have an end in sight to this, guys. It's not like an earthquake where we think, man, gosh, we're going to be back in our building in 3 weeks, and we really only have to look at this staffing model, or we're only going to be sheltered here for 3 weeks, and we only have to look at the staffing model for that long. This could be a while that we do this. So when you think about canceling those approved time off requests, do it, maybe as a last result. We already have staff morale problems. It's not exacerbated any farther if we don't have to. And I'll say that I've talked to a few providers that have had pretty darn large outbreaks that have been able to manage it with their existing staff without having to call people back in. But that's because the county let their positive staff work on the positive, with the positive residents. So after we do our staff recall, what's traditional in emergency management is a 12-hour shift model. If we lost so many people that we had to go to 2 12-hour shifts, like an AA team and a B team, we can do that. I don't think that's, you certainly can do it if it's a dire emergency and you have no other options, and the option is evacuation. You can go to a 12-hour shift if you absolutely have to. But I'm saying the same thing happens because this is going to be a long-term or more than a short-term kind of model. When you're in this emergency staffing thing, it may not be advisable to do the 12-hour shift. So as you go through the template, there's going to be a big section that's all highlighted yellow on 12-hour shifts. You're going to want to remove that that section if that's not something you're going to do. And then MOUs, that would be a memorandum of understandings. We call memorandum of, or MOAs, memorandum of agreement, whatever you want to call it. If you're a part of a chain and you have sister facilities that you can borrow staff from, that's one thing. You have other maybe neighborhood or folks down the street from you that have gone through this outbreak and come out the other side, and maybe they can send staff to work your positive side. I don't know, but make phone calls to those folks around you to see what their capacity is to help with staffing if something goes awry. And then the last part is registry. And we've all have a familiarity with using registry, although we've never had to use it in the manner in which we've had to use it during this event. But the expectation from just about every MOOC in the state and CDPH is that you're going to contract with a registry service before ever requesting for resources from the MOOC or from CDPH. And then the last part is having a process of contacting the MOOC for emergency staffing. Now, many of you guys have submitted PPE requests to the MOOC, so you know what that process looks like. It's the same process to ask for staffing. So in your county, they may want you to do it on their electronic reporting system. Some counties say just call this specific phone number. Some will say email us. Whatever the case is, your county specific requirement should go into the plan here under the contingency portion. And then you should include a copy of a blank resource request to show that you know the modality in which you have to request those emergency staffing resources. And then the last part is CDPH. Before you get to the point of evacuation as a result of staffing or for anything else, they want you to call the Medical Health Coordinating Center and let them know, because they may be able to get staff resources or whatever resources it is that's going to cause you to evacuate. They may be able to get it to you in a timely enough manner where you wouldn't have to evacuate. All right, and then the next part is designating staff. As we talk about designating staff, I mentioned at the beginning, the expectation is if you have a red portion or a COVID positive portion of your building, wing, unit, whatever it is, the staff that are assigned to work those COVID positive people, to the extent possible, they should be independent of the other staff. They shouldn't be in break rooms with other staff. They're not within 6 feet of other staff if they're passing them in the hall. That's when we say designation of space, that means it's the way I envision it is if you look at what it looks like before you come into an Ebola ward. Now, I'm not saying you got to tape up barriers and all that stuff, but I'm saying that there is a difference between what happens there and what happens in the remainder of the building. And that's what CDPH wants you to do. And I'll say I've talked to a number of facilities that have had this set up where they have a red section or have a COVID positive section, and they minimize the cross-contamination by keeping staff consistently assigned there, having all the stuff there, and it not going anywhere. Those sick people are not getting the remainder of the building sick. And that's good news, because if it is, then what are we doing here? But so we know that it can work, and we know that it is working if it's done in that way. So those are the expectations that CDPH is going to have. I think they're going to look pretty hard at our ability to be able to staff those things. So that designated space, we talked about it, kind of ad nauseum, but it's a red, a yellow, and a green. And as you go through the procedures, they're very detailed. They talk about having separate trash cans, separate medication storage areas, separate clean supply areas, separate dirty utility areas, beds no closer than 6 feet apart with the curtain pulled, attaching a regular cleaning schedule. All that stuff needs to go into that kind of thing. Now, if some of those things you go, man, I can't do this, or I can't do that, or my facility's not set up to do this, just remove that section of it in. But I want you to know that the real important parts are one, the cross-contamination. If people are doffing PPE, they're doing it before they're coming in to the remainder of the building. That has to stay in a separate dirty section, and that's got to stay within that section. So there are some real important things that you have to do. And then there's some other things that are best practice, like the clean supply area. We want to have that, but I don't know if it's achievable. Separate break rooms and respite areas so that the staff that work in the red areas are not commingling with the staff that work in the yellow or green areas. So really, really hard to accomplish some of these things based on the physical plant. These are best practices. These are things that we've seen as recommendations from CDC. So do them to the extent you possibly can. Okay, so as we talk about PPE, I mentioned at the beginning that the expectation from the state was that you have a rolling 14-day supply. And they didn't define what that expectation looks like. And I'll say that I've talked to a couple of MOOCs privately, and they say that their expectation is that you have 14 days during an outbreak. And I said, well, that's vastly different than 14 days where we only have 2 isolation cases a month. And it's a big, big difference. So if you cannot achieve 14 days over a suspected outbreak, even using like things like extended use where you're assigning one mask, for an entire day and telling them to wear that mask all day, think about whether that's realistic. And in the section on PPE, you're going to see a big highlighted thing. The very first procedure says add facility specific goal for the amount of PPE you're going to have on site. I frankly don't think 14 days in an outbreak is achievable. The gowns are still incredibly short supply, and there may be ability of you to get 14 days on an ongoing basis of certain things, but this is a 14-day expectation for all of them, and I don't know that that's achievable. So that's one of the things we want to make sure that you absolutely have to. Don't tie yourself to something that you cannot reasonably expect yourself to accomplish. But when you think about supply, think about it supply if you have an outbreak in your facility. Like, what does it look like if you have 20 residents in isolation? How much supply would you need for that? That's the kind of thing we want to talk about. And then a PPE coach. This is a new recommendation. This was on the checklist that they issued. It's not a part of the AFL, but it is a part of the checklist as a recommend. I don't know if these are recommendations or not, but they've essentially asked you guys to identify a PPE coach for each shift. And that PPE coach would be responsible for teaching the donning and doffing procedures. Now, you wouldn't have to teach the donning and doffing procedures per shift, but they have to be on per shift and make sure that the donning and doffing procedures that they taught are being instituted. And then my suggestion would be, if you've got this person identified and you're going to really have them tackle that donning and doffing thing, and that's really mostly what they do. Some of the other things that you can get them to work on is getting all of the staff fit tested. Find a fit testing kit, order it. Granger, a lot of these supply companies have fit test kits. I would order those and begin that process if you've not already. If you've got a vendor or somebody like that, there are many vendors that will come out and do mobile fit testing of your folks, but that would be another thing that my suggestion would be, to get that PPE coach to work. Now, I did not write that a PPE coach would work to get fit testing for all staff into the suggested procedures, but that may be something that you wanted to add if you want. And then I mentioned this, the coach would oversee the correct type of PPE is used depending on the color-coded space that those folks are doing treatment in. All right, sorry, I went too far. All right, there we go. All right, back to the, oh, I'm sorry, this is a bit of a repeat, but consistently assigned staff, clearly designated spaces. Okay, so they want these spaces clearly designated, and I've seen pictures all over the board of how folks are doing this. But I want to be clear, you guys can't compromise the egress of the building. You can't install like an air wall or something like that where it would block people from evacuating. So when we look at these, designated spaces, it doesn't have to be in the form of bisqueen, going across a hallway. It could be, a red dot, a giant red dot printed on a piece of paper, and that red dot start at the section of the hallway where the reds begin. And that red dot could be on every door in the red section. And you could do that a green dot on one section or yellow dot. That is an easy way that I think you could clearly designate the space, and people, I think, can get what needs to happen in each one of those spaces if you do the, red, yellow, green. Doesn't mean you have to do it that way. Doesn't even mean you have to set up your rooms in that color-coded fashion. That's just an easy kind of visual for people to follow. When they talk about that separate space, one of the big things is they want to minimize any flow through from a red space into the remaining space, or they don't want people that work in the red space to have to go through any of the other space. So to the extent you can, if there's a possibility of having a separate entrance, that is highly recommended if you can. And then those folks come in and out and they move through that portion of the building, and then they'll, that way we'll limit the cross contamination. And then we're going to follow our CDC guidance of when we move these folks, and then but also the local health department, because like I said, the local health department, some of them are more conservative, so you got to check in and make sure that the removal of transmission-based requirements is what's going to dictate when we move these folks out of those areas. And so as that changes, we'll have to adapt that. So that designated space is going to be flexible and adaptable, because let's say you have an outbreak and you've got a 100-bed facility, you got 87 residents, 20 of them test positive, and you're not doing any admissions, or you're admitting folks on a infrequent basis. You're concentrating on what you got now. You're going to have those reds, but eventually they're going to convert, back to a green at some point. So you'll have to have the ability to manage that when it happens. And when we talk about, the spaces, we want to identify, if we identify spaces that are just for dirty for the COVID outbreak, those sections of the building, not just the bedrooms, that are going to be designated for COVID, those should also be clearly delineated so that folks know that this is, in support of the COVID positive unit, and not to enter that thing. And then some of you guys that are really creative, I think you could almost do this in a modular fashion. If you thought about it, like how many staff can I get to do, or how many staff does it take to do 8 rooms? And how much staff does it take for me to do environmental cleaning for those 8 rooms? And how many nurses do I need to, can I just have one nurse dedicated doing med pass just in that area? Those things, if you could think about it in like an 8-room or a 10-room module, it may be easier for you to apply that or take it away. I don't know, but if that's for people more creative than me. Somebody brought it up on a conversation we had yesterday about building it into a modular kind of packet, and you go, I'm going to fit everything within this module. So I'm going to try to breeze through the last part of this, because the communication plan was very minimal what they asked for, but they did ask to assign a staff member. They asked for daily communications. They didn't specify what those daily communications will be about, or it looks like it's free for you to determine what that looks like. Maybe it's a note on your social media page. Maybe it's a recording on your phone line when people call in. Maybe it's an email to everybody, to every family member that you have an email for. So, and then this person is going to be the point of contact for staff, residents, and families. I will say they did specify that your communication with staff has to include an idea of what the PPE looks like in your building. So you'll have to do that. All right. And so the parts of this plan that are going to be consistently activated, which means that you're always going to have to be using those, is the testing plan, the infection prevention and infection control, the PPE, and the communication. Triggered activation is going to be after we get the outbreak. We'll go to cohorting. That we'll have our designated space in our brains and we'll have it mapped out. But as we apply that will be during an outbreak, and emergency staffing would be during an outbreak. All right, I know this was a lot of really super dense stuff to cover, guys. We're going to put the if the template is not up on the webinar or up on the internet within an hour or so, I'll make sure it gets posted to the CAF.org resource coronavirus page. And then if you guys want a deeper dive into each one of these specific 6 categories, I'm happy to do that, but I don't want to overwhelm you guys with information. And I want to leave you with this. I know we don't have a lot of time for questions, but as we wrap this up, I want you guys to understand that these are only things that other folks have used. They're not a recommend, or they're not requirements of you guys to do. I want you to look at those and say, can I achieve this or can I not achieve this? And does this make sense to me? And will it keep my folks safe, staff and residents included? And if you think there's something that needs to be added to there, by all means. This is not meant to be a static document. It's a living, breathing document, which you're going to have to update maybe frequently or maybe not at all. I don't know, but it's meant for you to customize, and I highly, highly, highly recommend it. And I'll just reiterate, if you've already developed your own plan and it meets those 6 components, you guys are good to go. Submit your plan and let us know what the results are. I don't know how much review these guys are going to do because we're going to send them 1,200 plans. So I don't know how much time they've got to read all these. But just our templates, 20 plus pages of pretty dense stuff. You know, I don't know if they're going to read them all to approve them or just use them when they go out to do their inspection. So we've got like 2 minutes for questions, and I sadly have a really important 2 o'clock call with Health and Human Services. So I could probably go over a few minutes extra. Courtney, do you got any highlights or anything that came up frequently?
Yes, we got a lot of questions, but I'm going to go ahead and do this one from Julie. She says, we had to put up a sealed tarp that blocked a whole egress and one hall under a lot of pressure from DPH to do so. This is in conflict with what you're describing. What do you advise?
Well, if you can walk through the barrier, in other words, if it's like, I'd have to see a picture of it, but if you can walk through the barrier, then it's not a compromise in the egress. But if the barrier is solid, then absolutely, that's a violation of the life safety code. And if a fire official came in and saw that, he would immediately rip it down. Next question.
Okay, somebody asked, do you have any idea how the state is managing or preventing spread of COVID in the dialysis centers and transportation companies?
No, I don't. And we've got a lot of, well, I shouldn't say a lot. I've gotten a few, and they could be anecdotal, but a few stories of folks where they can tie back the exposure to dialysis. Unfortunately, I don't know that there's an easy fix to that. All we can do is send those folks with, well, it's required that we send them with a face mask when they go. Now, whether they wear the face mask or not, that's up to the individual resident, but there's not a lot we can do about the procedures that happen in other buildings other than advocate to CDPH and tell them, look, hey, this is an exposure risk, and we're seeing actual cases as a result of this. But I'll tell you guys, we've seen a rapid decline in the size of the outbreaks once folks have gone to a universal masking procedure. even the outbreaks that we've seen are no longer these giant ones that you're seeing. We're seeing 4 or 6 or smaller numbers. That really works, guys. It really, really, really works. So if you're doing anything important, that's one of them. All right, next question.
Who is to pay for the testing of residents and staff, and what do we do with staff that are refusing to be tested?
Well, that's a great question. Cover the staff refusing, or if a resident refuses testing. I didn't cover that, but that's going to be up to you guys. There's, we brought this up with a couple of public health officials, and they said that if a staff member refuses to test, they said, well, that staff member is going to be required to wear full PPE, or is going to be required to do universal masking anyways. And if we're doing our symptom check, we should be okay if they refuse to test. Now, it doesn't mean we want to encourage them to refuse to test. In our sample procedures, the suggestion we have is just that you document the fact that that they have not, or that they've refused to test. What you choose to do with that information is up to you. We highlight a section in the procedures that would say you would attach your individual policy. I don't know that you need to go beyond that. I don't know. I think that's within their right, and certainly they're not forced to get a test. Some facilities may say, look, if you're not going to get a test, I'm going to hold you out from work for 14 days until you meet the return to work criteria. Or if you refuse to test, I'm just going to only have you work with COVID positive people because I can't be sure you're not positive and you're going to work with COVID negative. If you're in the middle of an outbreak and your staff says, I don't want to test, I'm absolutely not going to have that staff member work with non-COVID people, because you're in an outbreak and we have to assume that they were at high risk for that. So for those people, I would say, yeah, you're going to work COVID only. Now, this is me personally. You do whatever works for your building, but if you're in the middle of an outbreak and they're not willing to get tested, then they're working on the COVID positive section. That's for me. It just makes sense, and it puts too much risk on the people in the non-COVID section. So, or you could hold them out from work, or you cannot do anything. It's up to you guys. You guys get to make that choice. But I think if they do refuse, just make sure you document it. Next question, Courtney. I'll go 2 more minutes.
Okay, any indication when the state will mandate hospitals to test patients prior to discharge? We are still getting pushback from some hospitals prior to discharge to our SNF.
Yeah, no, it's absolutely correct. It's in the list of, so the CDPH sent out a list to every public health department in the state that gave them a prioritized list of who to test. And there's 5 things in tier 1 as a priority. And one of those 5 things is a discharge from a hospital. So CDPH has told every local health department in the state that these folks need to be tested. Now, it's not a mandate, it's a suggestion. And they did the suggestion based on the lack of testing supplies or reagent or a number of other limiting factors. But if your county is still not doing that, I want you to send us an email and just say hospitals in X county are not doing testing regularly of discharges to SNFs. We want to know that. Just send it to info@caf.org, or you can send it to me or Patty or any of us. We'll take that information and directly push it to CDPH, because that's one of the primary vectors of how this comes into our building, and we want to eliminate that risk if we can. So, all right, that's all the time we've got for today, guys. Thank you so much for joining us. If you would like to have a deep dive into each one of these sections, where you want us to go over it for half an hour, an hour on a webinar, you email me or email info@caf.org and let us know, and we'll set those up. But I don't want to kill you guys with information. I just want to give you a starting point and let you go at it. And if you're having problems, why don't you send us some emails and we can address it. But if I get enough requests, we'll just set up a webinar to do it. All right, thanks guys. Have a great weekend. Take care. Stay safe.
This is Courtney. Before we go, I just want to say follow up with the other questions that we received via email, and I will be sending out an email to everyone that was on the webinar today. I saw that I got several calls regarding today, so I'm going to be calling you back and thank you.
Hey, Courtney.
Courtney,
nobody can hear you. Your voice is all jumbled.
Okay, thank you.
All right, guys. Thanks very much.